Hello, good afternoon, everyone. You're welcome to this webinar session on far-reaching effects of mitigating the medical and financial impacts of COVID-19. My name is Temitope Oke, and with me today are my colleagues from Farm Access Foundation and a speaker from the Emergency Operations Center of the Lagos State Ministry of Health. Together, we will be taking you through this session. And I would like to welcome you once again. And I will be handing you over now to the moderator of this session and all other speakers that will be coming up after her. Thank you very much. Dr. Anire, you're up.
Yeah, thank you, Dr. Oke. Good afternoon, everyone, and welcome to today's webinar brought to you by Farm Access Foundation with support from Novartis. My name is Anire Asuma, and like Dr. Oke said, I'll be your moderator for the day. I think we should quickly go through some housekeeping rules. Please keep your microphones on mute throughout the period of the webinar so that we can minimize distractions. And drop your questions in the Q&A panel, not in the chat panel, because if they're dropped in the chat panel, we're likely to miss the question. So please remember to drop your questions in the Q&A panel. We will answer as many questions live as time permits. And for those that are not answered, we will send responses to all attendees via email. Because we have a large number of participants joining at the same time, we may experience technical glitches. Kindly bear with us if this happens, but be assured that they will be resolved within the shortest possible time. So again, I welcome you. If this is your first time joining our webinar series, we're glad you could make it. If you're a returning participant, thank you for reconnecting. As we all know, COVID has been with us in Nigeria since the 27th of February this year, and we are yet to see its end. Via various platforms, we've talked about the disease, its direct effects on our bodies, as well as preventive measures to take against being infected. Today, we'll focus on some of the indirect effects of COVID-19, or what we refer to as the far-reaching effects, specifically from the medical and financial points of view. And to take us through this discourse, we have two expert speakers with loads of achievements under their belts, but I'll have to summarize for the sake of time. So we have Dr. Adefolari Opawoye. He is a physician with specialization in infectious diseases. He was one of the first indigenous doctors involved in the Nigerian Ebola emergency response in 2014. He currently serves as an infectious disease physician at LUTH, and he is the IPC team lead for Lagos COVID-19 Emergency Operations Center. Outside of medicine, Dr. Opawoye is an expert compere and an award-winning public speaker. Welcome, Dr. Opawoye. Our second speaker is Mr. Olufisayo Okosoya. He is a strategy and business development professional. He was responsible for preparing the Nigerian Banking Industry Review, which is an in-depth analysis of the banking industry. He has held strategic leadership positions in some companies, including Archminster and Verse 29 Group. Fisaya has been a delegate to policy review summits in Nigeria, Ghana, Kenya, and Japan. He currently serves as the Business Development Director for the Medical Credit Fund in Nigeria, a part of the Farm Access Group. Thank you both for agreeing to speak today, and I guess we can go straight into the business of the day. So Dr. Opawoye, over to you. Please let us know what the mitigating, how to mitigate the impact, the medical impact of COVID-19.
Oh, thank you very much, Aniri. Thank you very much. It's always a pleasure and a privilege to be here. Sometimes I don't know where Farm Access research is. They're very deep topics, which a lot of times I always complain that these are things that you really have to think through before you come up with even a presentation. It's not really something that you could read somewhere, because you really have to make it indigenous and make it applicable to the Nigerian environment. So it's always very tasky, and it's a pleasure to be here once again. Like you said very clearly, that COVID has been here for a while now. Yesterday made about 6 months when it was declared as a public health emergency of international concern. and we still don't have an end in sight. So quickly, we're going to be looking at the mitigating the far-reaching effects of COVID-19, and we'll basically be looking at the medical impacts. And my friend Okusoya is going to be looking at the financial impacts. Always great to have an expert financial guy on board. So this is a table of contents that we're going to be running through, and just quickly within the next few minutes, we're going to be tasking ourselves and having a discussion on the effects of COVID. But before we start, let's quickly look at an introduction of COVID, just a brief summary, and into the lecture itself. So let's move to the next slide, Mr. Collins. So basically, COVID-19 is a new viral disease originated in China and spread all over the world. The truth is we have not seen anything like this in recent history. And it has fundamentally changed the way we live. Current data shows that there may be no end in sight. Despite initial promising studies that show that maybe we look at herd immunity or we look at vaccines, the current data we have shows that, look, all those things may not be achievable. And when you look at something like HIV that has been here since 1981, despite billions of dollars being spent, and we still don't have any real, we don't have a cure, we don't have a vaccine for that. So it helps to put in perspective that these things are not magical solutions. And the reality is that we may have to adapt and evolve to the new normal. So people keep asking the question, when are we going back to our normal lives? When are we going to do our parties again? When are we going to do our shows again, our clubs again? But the reality is that we don't know. And we may just have to find a way to move on despite COVID. But the real measure of the impact of COVID is something that it will take years. It will take decades from now before we can really be able to estimate that. So this is just going to look at some of the things that we have seen. Now, just a quick timeline, of course. December 2019, the WHO was alerted to a cluster of pneumonia cases in Wuhan. And the Chinese CDC discovered a new virus in January 9. And by February 15, we had the first case in Africa, in Egypt. South Africa currently leads the way in Africa. We have January 5th, disease of public health emergency of international concern. And the first case was identified in Nigeria in February 27, 2020. That's the next slide now. And by March, the WHO declared the disease as a global pandemic. And I recall when this declaration was made, it was felt that it was premature and the WHO was just panicking, but they have been vindicated that this is truly a global pandemic of the sort that we have not seen. The first case, of course, in Nigeria was the first case in Lagos was a Nigerian that came back from the UK in March 13. And by July 27, that's just yesterday, we have more than 40,000 cases have already been identified in Nigeria. Ladies and gentlemen, the reality is that we don't know where we're going. We started from 1. We had 40,000, and we all know that we may need to test more. So when we look at the impact, I look at the effects on the patients, effects on the healthcare workers, and the effects on the healthcare economy as a whole. When you look at the patient, the reality is that we have seen a definite reduction in health-seeking behavior, in which people are not even coming to the hospital at all. People are not coming to the hospital at all. There's a poor access to healthcare because of the lockdowns. There has been a lot of cancelled appointments, postponed surgeries, cancelled medical checkups. And because of the fear of COVID, there's a lot of misdiagnosis and mixed vaccines. We're going to be trying to talk about the more about this in the next slide. So basically, what we have seen since COVID started is that there has been, people are no longer going to the hospital because everybody is afraid that they may catch COVID in the hospital. And so that particular blood pressure that you're supposed to pick early, and instead of picking it early, the blood pressure gets worse. And then by the time the patient presents in the hospital, present because of a stroke. So in a study that was done by the WHO to look at what has happened since COVID occurred, they looked at 155 countries. And they discovered that most of them have had a definite decrease in inpatient volume due to cancellation of elective care. Many of them, so people wait until they are very sick before they come into the hospital, and that has a lot of effect because eventually, so a lot of these patients, they may have reached the point of no return before they come. Also, the screening programs are closed down. because of issues with transport, there's been a lot of in-depth access to health facilities. For example, in Uganda, about 7 women who were in labor died because they couldn't access the hospital because there was a lockdown. Thankfully, the lockdown has been lifted in Nigeria, but even despite that, we have seen that there has been serious problems because there's still a curfew, and there have been serious problems with transportation. And you can imagine somebody falling into a labor in the night when there's a curfew, and these people don't have cars. You can just rather imagine the kind of stress that they would go to. Also, we have seen a situation where a lot of resources have been committed to COVID care, in which other doctors that are working in other areas have been redirected to COVID care. And when this happens, what we say is that remember that COVID is not going on strike. When COVID is raging, other diseases are not going on strike. Other diseases are not taking a break. Hypertension is still there, heart failure is still there, diabetes is still there, cancers are still there. And that's been the challenge generally when that's been the challenge where a lot of times we have not, we have the resources, the doctors, the staff that are supposed to take care of these other conditions. They are being redirected towards COVID, and then it becomes a big issue. And because of that, we, of course, PPE is a big thing that we keep talking about so many times. Because there is no PPE, a lot of private hospitals are no longer seeing patients at all. And so they are directing these patients away, and the public institutions are overwhelmed, and a lot of patients actually die en route to some of these public institutions. Also, we've seen a lot of clinics closed because of issues, again, of fear of spread. And also, we've seen decrease in outpatient volumes and unavailability or stock out of essential medicines because COVID has affected shipping, has affected transportation globally. So a lot of drugs that we don't produce in this country, we have run out of them because they are not coming. These are some of the effects that COVID has seen on the patient. And we can see that the effects are actually far-reaching and actually devastating. Next slide, please. And so when we look at, for example, when you look at vaccinations, and this is talking about the US, and they looked at vaccination, and you could see it crashing all the way from January, pre-lockdown, and by the time they entered the lockdown in March, and then they went into April, you can see the graph as it keeps going down, the fact that from the point in which March 13, the US declared a national emergency, a lot of children were not getting vaccines again. And this is a big problem because the vaccine-preventable diseases like whooping cough, like diphtheria, like measles, I mean, they are going to be on the rise. They are going to be on the rise. Maybe not now. We may start seeing some of these effects decades from now, or some years from now, because the children that are supposed to be vaccinated now are not getting vaccinated. The parents either cannot get to the hospital, or they're afraid that they'll get COVID if they come into the hospital. And then all of a sudden, these children come down with some of these illnesses, and then they have all sorts of sequelae that could have been prevented. Next slide. So, for example, when we looked at WHO survey of 155 countries, again, we saw that 53% of them had disruptions in treatment for hypertension, 49% in treatment for diabetes and diabetes-related complications, 42% for cancer treatment, and 31% for cardiovascular emergencies. And so we have seen that non-communicable diseases, which actually kills about 41 million people every year, and most of these deaths are in countries like Nigeria, it has been totally neglected. And because of this neglect, and you can't blame the government or the health sector, the COVID has just been overwhelming. But what we are looking at is this. I mean, at the expense of, COVID is being treated at the expense of these other patients. A lot of funds that should have been directed towards this care is being directed towards COVID. And all of a sudden, we are having a catastrophe on our hands that we are not seeing the big picture even from now. Next slide. And one of those things that we're seeing is that there's an increase in non-communicable diseases, there's an increase in vaccine-preventable diseases, and most importantly, ladies and gentlemen, there's a worsening mental health. And this is a very, very big problem because you cannot really measure mental health. I mean, except you start seeing some certain signs, it's difficult to be able to really quantify. But what we've seen with COVID is that it has caused a lot of stress. It has caused a lot of stress on many people. When you have a typical patient who has COVID, the patient is worried and asking himself, who brought it into the house? Who have I given it to? Is there any other member of my family that is affected? And you can see this worry and concern on their faces, and they don't know, okay, can I go and greet my children? When am I supposed to go home? What am I supposed to do now? We have seen people who had COVID and were sacked from their workplaces. We have seen people who had COVID and they lost their families because all of a sudden their husbands or their wives ran away from the house because of COVID. And some of these things, we are definitely seeing a possible increase in suicides in some countries like the US, all because of the social distancing, the physical distancing, and the isolation, all from COVID. Again, some of these things are issues we're going to realize much later. They may not be full effects that we're going to see now. Next slide. So again, in keeping what we have been saying, the fact that in other countries like in India, a lot of acute cardiac emergency, myocardial infarction, they are not getting to the hospital. When you compare it to 2019, in March 2020, a study showed that 30% fewer of them made it to the hospital, probably because of lockdowns and because of the issues that are going on. And the number of people newly diagnosed with cancer in Netherlands dropped by 25% as a result of lockdown. So it means that the average person that's supposed to come to the hospital and get diagnosed is not getting this diagnosis. And because of that, the cancer that you are supposed to speak when it is a very small lump, you don't see it until it has metastasized everywhere. And so somebody who potentially could have saved their life or his life, if you pick up the cancer early, will end up dying from something that is potentially preventable because they did not come into the hospital. Next slide. Let's look at some graphs now, some charts. And we can see in the slides, for example, this was a study in the US that was looking at exposure of children to cleaners and disinfectants. Now, all of a sudden, everybody has one jar or the other of disinfectants in their houses. People are panicking. Everybody has hand sanitizers all over the place. You have bleach all over the place. And what's happening, even in countries that are far more developed than ours, is that there are increased in accidental ingestions of these toxins, of these horrible chemicals. And you can see the graph. You can see in 2018, that's the thin blue line, in 2019, the thick one, and the black line, 2020. And you can see the definite spike in the cases of who were exposed to cleaners and disinfectants, all because they are now more accessible in the area. And these are some of the effects, because now a lot of children are getting exposed. People are getting all sorts of bronchitis. People are getting skin reactions from many of these issues. Now, almost a lot of people have chlorine in their houses, which they did not have before. Next slide. Again, the next slide shows another graph. For example, this is from the data from the WHO, looking at the disruption in activities in a lot of non-communicable diseases like asthma, like diabetes, like hypertension, cancer, and all that. And we can see that in a lot of countries, it is totally disrupted, or at least partial disruption, because of lockdowns, because of the fact that a lot of people are not coming to the hospital, people are not doing routine checkups. All these are big issues that is causing major disruptions in this life. The next slide, for example, also shows another graph looking at different phases of the lockdown. For example, the blue one was when it was just the blue one was when that it was sporadic cases, okay, and then the orange one, the brown one, pardon me, is when we had clusters, and then when we had sustained community transmission the last time, and we can see that at each level there's an increasing level of disruption. For example, we had level of sporadic cases in Nigeria in February, March, and then by the time we were in later in March, we had clusters, and by the end of March to the beginning of April, we had sustained community transmission, and there has been a graduation in the level of disruption in the care of various non-communicable diseases. And this is why I tell people, mortality is mortality, regardless of the cause of that, whether it is COVID, or it's cancer, or it's diabetic emergency, or it's hypertension. All those things are crucial. All these things are, none is more important than the other at the end of the day. All of them are going towards one end result. And that is why we cannot afford to neglect the care of some of these other conditions. When we look at the next slide, for example, I've talked about immunization and the fact that more than 100 million children worldwide are at risk. Most countries have suspended immunization programs. Diseases that are thought to have been eliminated may stage a resurgence. Because recently we got our certificate that we have eradicated polio. But these are things that you have to keep sustaining the vaccination, or else it may show up again. I remember that record keeping for many of those things are poor in this country. Most people, their record of vaccines is just for the modest, and then we have to really look at that. Now, let's move on to the effect on the healthcare workers. And the healthcare workers have really, really suffered in this COVID because unlike any other infectious disease, I mean, many of us as healthcare workers, as doctors and nurses, we've dealt with hepatitis, we've treated lots of HIV patients, we've treated lots of TB patients, and most people have been fine. But the reality is that close to 30 to 40% of people involved in COVID care all over the world have gotten infected at one point or the other. So a lot of healthcare workers have fallen sick, and some of them have died, quite a lot actually. Even in Nigeria, we had quite a few deaths, and years of training and experience have been lost because of the disruptions from COVID. Remember that with every senior, because we know that COVID affects the elderly predominantly, and with every senior medical doctor that dies, you lose many years of experience, that person cannot pass on that knowledge to the other generation. And then we've seen situations where the training has been disrupted. For example, a lot of exams could not be held in many of the postgraduate medical colleges because of COVID. And also, we should remember that fatigue is also a big issue. People are tired. Some people have post-traumatic stress disorder from the patients that they have been seeing. We will look at the hospital as a whole, the health institution. And this is where a lot of the public needs to get it right. That despite the fact that people think doctors are the ones cashing out in this pandemic, the reality is that even doctors are suffering. And the doctors have not escaped the devastating effects, financial effects of COVID-19. A lot of hospitals have been closed due to reduced patient turnout. For example, if you have an hospital that all they do is cardiovascular checkup, who's going to check his blood pressure now when you're afraid that you may get COVID? Everybody's on a lockdown. You are going out, you must have a strong reason. So that patient that will come in for a normal check and will pay for his consultation fee for that, and then you charge him for ECG, charge him for echo, all that is gone. And then all of a sudden, many of these hospitals, they cannot pay their staff anymore, and they have to they have to close down. These have been big issues. There have been severe reductions in hospital revenue. And next slide, even those who have been involved, involved in care of COVID, next slide please, have not been spared because let's move on to the next slide, Mr. Collins. Because even a lot of people see hospitals that have been involved in COVID care, especially private hospitals, and then they believe that, can we go to the next slide? And they believe that they are making a lot of money. But this is not really true, because I've been intimately involved with many of these hospitals. And the reality is that there's a high level of expenditure that is used in the care of COVID patients. For example, you spend a lot of money buying PPEs, you spend a lot of money paying the staff, because you have to pay them hazard allowance. A lot of staff have to be fed, some have to arrange accommodation and transportation for their staff. So at the end of the day, when you look at the net, it really doesn't come to much. I mean, it doesn't come to much. And for the first time, we're looking at the possibility that the health industry will suffer a recession. And this is going to be devastating, because we're going to see large numbers of people that are probably going to leave the health sector because they are no longer making money there, and they're going to go into other sectors, or they may leave the country, as we are seeing doctors leaving the country every single day, just trying to go to better pastures. Next slide. Charles Darwin, the father of evolution, said, "It's not the strongest of the species that survives, not the most intelligent. It is the one that is most adaptable to change." And the reality is that we need to adapt and evolve to COVID. COVID is not going to go anytime soon. The best estimate shows that we may still be here this time next year. Of course, cases will reduce, it will peter out, but we'll still have to deal with the reality. And so we have to now look at a way where we can safely move on with our lives and yet be safe and be able to continue a semblance of normal despite COVID. The next slide shows the next slide shows some of the things that hospitals will need to do to try to mitigate the effects of COVID. Next slide, please. And one of those things, which is very important, for example, is the use of telemedicine. And a lot have been said about telemedicine. A lot of doctors are not comfortable with it. A lot of patients are not comfortable with it, but that's the way to go. And that's the reality of what we are dealing with. the fact that we need to look at the deployment of telemedicine, look for a way to be able to, I mean, the average Nigerian patient does not want to pay for consultation on the phone. And then he just wants to call you, look, guy, Alpha, I'm having a headache, what should I take? Oh, do this, do this, do that. And then he says, thank you, and goes. That has to change, because that is going to be the major means of our consultation from now on. So that we are seeing, you are saying, we have to look at role delegation and look at shifting tasks. So what are we talking about? What about doing home visits? What about doing home care for patients? Okay, fine. You cannot come and take your vaccine in the hospital, or you have an injection, you cannot come to the hospital because you are afraid. Then we can send someone to your house and we're going to charge you for it. And these are things that we have to start looking at. These are things that we have to start redesigning and revamping our space so that we can be able to, despite COVID, be able to move on with our lives. We have to look at new dispensing approaches for non-communicable diseases. For example, a patient is hypertensive, is diabetic, is supposed to have drug refilled. Can we do delivery of these drugs? Can we carry the drugs to his house? He doesn't have to come to the hospital, just stay there. We have zero contact delivery, contactless delivery. We drop it at the point for you, you pick it up, and everybody is fine. You are continuing your drugs, we supply your drugs to you, and then, you know, everybody is good. And also, at this same point, we have to look at how we can redirect all the patients to alternate healthcare facilities. All of us cannot be involved in COVID. I see COVID patients every single day, and I've been doing that for about 6 months now. And everybody cannot do that. Some people have to still stay in the care of other conditions. I recall one of my senior colleagues who I was talking about, and she was telling me way back 3 months ago now that I'm going to dedicate myself to non-COVID care. And she has been doing extremely well with that. And then when she sees any COVID patient, she sends to us. So that's the reality of what we're dealing with now. And then we have to look at empowering patients through self-testing and diagnosis. So yeah, hypertensive, please check your blood pressure. Check your blood pressure, send it to me via WhatsApp. I'm going to do a consultation for you on that. And then your blood pressure is high, I will tell you what to do. Oh, you're diabetic, can you test your own sugar? We need to get patients involved in their own care, and most importantly, find a way to bill for it. If we do all these things, we are trying to take care of the patients, and we also take care of the doctors, make sure that money is still coming in somewhere and the stress is not enough. And the reality also is that we have to have increased budget allocation to health. If there's anything that COVID has shown us, that has shown that health is seriously underfunded in this country, and we need to make major investments in the health sector for things to move. All these things are not cheap. Telemedicine solutions are not cheap. All these things are things that we need to totally revamp the way that we have been doing things. And to do all of these things successfully, we need a lot of brains, we need a lot of resources, we need a lot of money to make things to work. Next slide. So, ladies and gentlemen, over the last 20 minutes, we have been looking at the medical effects of COVID-19. Next slide, please. And we have seen, we've seen that the reality is that, can we go to the next slide, Mr. Collins? It will take us decades, to realize the true impact of COVID. And we must not develop tunnel vision while in the throes of this pandemic. It's the reality of we have to expand our vision and see that life goes beyond COVID, and see that all things are raging, and look at a way where we can take care of COVID and still find a way to take care of all these other things. Today, for example, is World Hepatitis Day. We have to celebrate that. Hepatitis is a very devastating condition. Hepatitis B, Hepatitis C. And one of those things we have seen is that, for example, a lot of people have missed their vaccinations since COVID occurred. And then those people are going to develop cancer 20, 30 years from now. Those are realities that we have to look at. So do not develop tunnel vision. You have to expand your vision. You have to look at COVID. And then we have other guys that are looking at all the things. And we are chasing all these things together because one cause of death is not more important than the other one in the long run. The health sector needs to create dynamic solutions to deal with the devastating effects of COVID-19 in a way to try to mitigate this effect. We have to be dynamic. We have to be creative. We have to think outside the box so that we can move on with our lives. Thank you very much for listening, ladies and gentlemen. The next, I've shown my references, and these are the credits for this presentation. Thank you very much. Over to you, Aniri. Thank you.
Thank you very, very much, Dr. Opawe. That was a very interesting session. I think one of the quotes I'll take away from today is, when COVID is raging, other medical conditions are not going on strike. In essence, disruptions are happening all over within the medical space in terms of mortality that we get from other conditions. There's still disruption with training and transfer of experience. So we need to look into the future and make sure we begin to put things in place to salvage the future. Thank you very much. I think we have a few questions for you already, and we'll quickly go through those questions before we go to the next speaker. So someone says, why do you say there is no end in sight to COVID-19 when there is a vaccine in the offering?
Thank you very much, Dr. Aniri. Now, basically, what we know about vaccine science is that it's not very straightforward. I mean, people are getting very optimistic about some of these claims, and some of them you have to really look at them with a very thick-tinted lens and ask yourself, what exactly are they doing? Some of these vaccines are just in trials. Some of them, for example, the one from Moderna was testing only 8 patients. That's nothing in the grand scheme of things. So vaccines, we've seen that it's not really easy to develop. When the effectiveness is questioned, sometimes it's not effective on everybody at the same time. For example, if you give everybody hepatitis B, it's not everybody will be protected from it. So the reality is that yes, there's vaccines in the work. The reality also is that it will take some time before we see the true effect of this vaccine. So for now, there's no vaccine development. It's going to take a very long time before we see that. And also, another worrying thing is this latest study that is coming out about antibodies that is showing that antibodies to COVID may not last beyond 2 or 3 months. And the question is, does disappearance of antibodies mean disappearance of immunity? But one thing we are seeing 6-7 months into this pandemic is that we are seeing definite cases of reinfection. So when is the end? We don't know. And we just have to think and fashion our lives in a way that, okay, if this thing does not go away, what can we do? And that's what we're trying to discuss. Thank you very much.
Okay, thank you, Dr. Opawe. You talked about a lot of research being out there. So I think today the news broke about there was something that went viral on social media, a certain Dr. Stella Emmanuel, and someone wants to know what is your opinion about that. So she came out to say that hydrochloroquine is effective in COVID-19, and I think she had treated 350 patients using hydroxychloroquine, zinc, and some, I think, azithromycin, if I'm not wrong. What is your take? Someone is coming to claim that hydrochloroquine works when research says it doesn't work, or that there are some effects using hydrochloroquine.
Thank you very much, Aniri. So the interesting thing was that the first time I saw the video was when a patient's son actually sent it to me via WhatsApp. Like, okay, fine. My mother is on admission. There's this drug that is working like mad in the US, and you guys are not using it. And that was the first time I saw it. And I was like, oh my God. I was quite disappointed, really, in the video, because it's not scientific. That's not how we practice science. Science is methodical. You don't come and make claims on TV. I mean, if you've treated 350 patients, please, can you present them? Can you publish them? Can you take a study on them? Publish them, tell us your experience, and then let the study, let the publication be peer reviewed in a journal, and then your peers look at it and say, okay, they are satisfied with your methods, and then we go on like that. That is how science works. So what she did was not scientific. What she did was not really ethical when you look at it, because it's going to confuse so many people. And I've told you about a patient's son already challenging what we were doing in the care of the mom, because he believes that, oh, look, for God's sake, I mean, this thing works, I am not giving it to my mother. So, so we have to be very, very careful when I get this kind of information. A lot of information has come out. It seems to just be a political stunt and not a scientific one, So studies have shown the Solidarity trial, hydroxychloroquine has been withdrawn from it. Recovery trial in the UK, the same thing. We are still looking at it in Africa, really, and hopefully very soon the results of those trials will come up. But what we know up till now is that hydroxychloroquine doesn't make much of a difference, and even sometimes it may be more detrimental to the patient, and that's what I would say on that. Thank you.
Okay, thank you. So to everyone listening, please, not everything that circulates in social media should be taken, completely. We need to be sure that there is good evidence backing it up before we start circulating and letting everybody know what the true picture is. Another question, I think we'll take one more question before we go to our next speaker. Most people thought COVID-19 will wipe out Africa, but now we see the cases are lower than some other countries. Beyond testing, what do you think are the potential factors for the low rate?
Okay, thank you very much, Dr. Anuri. So basically, I like the fact that the person acts beyond testing, because the reality is that testing is the major reason. If you don't test, you don't find it. And that's why the US has the highest number of cases, about 4.3 million, because the US every day does hundreds of thousands of tests. Potentially, the US does more tests in a day than we have done since this pandemic started. And even with all that, the US is still saying that, okay, fine, maybe we are not really seeing the true picture of the disease, because there's a lot of asymptomatic infections, and that the true burden of the disease may be 10 times what's recorded. So what we are saying is that let's not be deceived by the numbers we are having in Nigeria. We are not tested enough because of various reasons, which I cannot start to state now. And the same thing is affecting our death counts, because the way we count our deaths, so what I'm aware of, is that the patient has to be laboratory confirmed before you say the patient has died. So when a living person is not getting a result in 3 weeks, which used to occur before, things are far more better in Lagos than in so many other places in the country. How do you want to know somebody that died not die of COVID? So let's not be, we know that, again, maybe it's safe to assume that people are not dying as much as they are dying outside the country. But I tell people every single death is important. It is important to that family, important to that loved one, important to that person that loses somebody. And so even one person dying is too much. But we should also not be deceived, because we are not testing enough. We are not getting quality data. And also remember that we don't have as much elderly population as they have in some other places in the world. So those might be the factors responsible for the low death rate. Thank you.
Okay, thank you so much, Dr. Opawe. Please don't go away. We may still have some questions for you after the second speaker. And then to all attendees, please post your questions in the Q&A panel and not in the chat panel. Thank you. Okay, so we're going to go to the next speaker. Fisayo, over to you.
Good afternoon, everyone. It is a privilege, just to get the opportunity to share some of the things we are doing and share from our experience about where the global, national, and even local economy may be going after COVID and the effects of that on any healthcare business. I'd like to start with a thought. And this thought was shared by the Minister of Finance, of Petroleum, sorry, of Saudi Arabia. So I'll use that thought to set the context, as it were. He said something quite interesting, and I'll show you a few images to buttress this thought. First of all, there's this picture of the caveman who, to all intents and purposes, is doing everything right and is living his best life. And he said that the Stone Age did not end because humans ran out of stones, and the oil age will end long before the world runs out of oil. This was said by Sheikh Ahmed Zaki Yamani in the year 2000. And interestingly, it is very instructive that it was a comment about energy moving away from oil and gas, and it was made by someone who was Minister of Petroleum for one of the largest oil powers in the world. And it's so instructive for a country like Nigeria to say that there will still be oil in the ground and the oil age will end. The clean energy age will come and there will be other things that we will do. But there will still be oil, which means the value of oil will go down. And then William McDonald, sort of rephrased that statement and said the Stone Age ended because it was time to rethink. And this is essentially the theme of what I want to share today, that it's essentially time to rethink everything we do. Someone said something about a paradigm shift. And the idea was that a paradigm shift occurs when there is a shift in the fundamental thinking that drives every single thing we do. And in listening to that person speak about the paradigm shift, what he said was that when there is a paradigm shift, everybody goes to zero. And I want you to let that sink in for a bit. That anytime there's a paradigm shift, everyone goes to zero. It means that the paradigm shift is a leveler. And at some point, I'm going to talk about the effect of COVID-19 on the financial system and the business system and how it can be a reset button. But let me lay the foundation by saying that before the pandemic, the Nigerian government had been grappling with weak recovery from 2014. We hadn't yet come out of that shock of low oil prices. I mean, we were coming from a place where oil prices were 100 and something naira per barrel, and we were growing in leaps and bounds. Our foreign reserves were growing to come to a place where sometime between this year and last, oil prices were as low as 30 naira. Now, if you understand the way we work in Nigeria, we don't have a very robust economy. We have quite a narrow economy that's a mono economy. So when I say mono, it means mono revenue. So we spend oil money. If oil money is short, we don't have money. So the government has a budget and the government has a benchmark against that budget. That benchmark is the oil price benchmark. And so it's like you make a benchmark to say, I sell shirts and my shirts will go for 5,000 naira in the open market and I make my entire budget on those shirts. And then you find yourself selling the shirts for 1,500 naira. Immediately, you know that there's fiscal issues. You're going to have challenges. You're going to have challenges for capital projects. You're going to have challenges funding what you said you would do in the budget. And you're going to have challenges even paying salaries at some point. And one of the ways to help yourself when those challenges come is to borrow money. And we have been doing a lot of that recently. So our debt to service ratio has been 60%. For those who are not numeric, what that means is that for every 1 naira, our debt service to revenue ratio, for every 1 naira that we make in revenue, we pay 60 kobo to the debtors. So what's left for us to do anything with is 40 kobo. And the idea with COVID-19 and oil prices falling, our revenue is likely to decrease. So at some point, we have less money to spend. And what that means in an economy like ours is that household consumption will drop, right? As a result of obviously partial and full restrictions on movement. We have a daily economy here, no expectations of future income, particularly by workers in the gig economy. That's what we call the daily economy, short-term contract basis, you know. And then erosion of wealth. An erosion of wealth from two angles. One, decline in assets, you know, from the stock market, right? And spending, people now touching their savings because they've lost their jobs, you know, and also people losing wealth because of spending on medical emergencies. Like COVID-19 has become a biosecurity threat. So if someone were in an ICU for a space of 3 weeks, it could erode the family and send them back to a middle-class family can be sent back to poverty as a result. You know, investment firms are running away due to uncertainty. Foreign direct investment craves stability in any economy. Whatever happens, at least let us know your policy direction. Let us know what you are doing. It doesn't matter what the outcomes are, let us know what you are doing. But because of this pandemic, there's limited knowledge. So everybody's asking. And I saw that question in Dr. Payo's session also. How can you say COVID will be here till next year when there's a vaccine in place? Let me tell you, we really don't know. And this is the truth, and we must face this reality. And that limited knowledge, nobody knows when COVID will pack up and leave, or whether it will be here. That limited knowledge actually now leads to, it's bad for the economy because the economy thrives on certainties. Now, effects on COVID on the Nigerian economy. Countries are shut down around the world. No one is traveling anywhere. And I decided to put it this way because I wanted to be blatant about it. I like to say sorry to those of you who have missed your summer holidays, but you understand, no one is traveling anywhere, right? Amid travel bans and lockdown, if no one is traveling anywhere and there's a lockdown, immediately airplanes and cars, which are the biggest demanders of crude oil products, right, they don't need those products anyway. So oil and gas companies are losing revenue. Oil and gas countries like us are losing revenue. Essentially, again, no one is going anywhere. And I want you to think about it because it's quite instructive. Because it has a flip side. In the midst of the lockdown, no one is likely to be thinking about fine dining. So that's the hospitality industry, restaurants gone down the drain. Lockdowns affected the shutdown. So no one is going to any hotels to stay, So in other times when the dollar rate fell, Nigerians went to hotels just to, feel like you're going on vacation, but no one is going anywhere now. The hotels are shut, right? Event centers are shut. I want you to think about the quantum of money that has been lost in this economy for every single day that economy is shut down. Now, because we don't have a lot of data, it's hard to quantify, but it's a lot of money. And that has resulted in a lot of things. So hospitals lost revenue, and Dr. Pyle mentioned this already, where patients are skeptical about visiting. You hear people saying, oh, I'm going to postpone the immunization of my child because I don't want to now go and pick up something, a hospital infection. And so loss of revenue, right? Loss of jobs, changing industry landscape. Now, this is not all bad because I'm going to present the positive aspect, but it's a changing industry landscape. Now, if you look at the condition of the healthcare industry right now, we have primary care, secondary care, tertiary care, right? Nigeria has a very fragmented healthcare industry, right? This fragmentation is a limitation to growth, and we keep talking about this fragmentation. And I'll give you an example of what it means. If you look at tertiary care, for instance, or secondary care, I look at an expensive machine like an MRI or a CT scan, and I find that everybody wants an MRI or CT scan. Now, in what we do at the Medical Credit Fund, where we give loans to hospitals, the first question we're wired to ask is, you want an MRI or CT scan? What's your referral number? How many patients do you refer out in a day? And the guy says 2. And you're thinking, how do I break it to you that when you get this MRI, you need to have at least 15 patients being referred out in a day? How are you going to pay back for the MRI that's going to cost you $1 million? Now, $1 million last year was 360 million naira. $1 million this year is 460 million naira. So that fragmentation reduces efficiency, right? Up till now, there's not been efficiency because everybody wants a CT scan. Everybody wants this. Everybody wants all that. So it reduces efficiency. And I'll show you how going forward in the future, COVID-19 is going to force efficiency because of the lack of resources, right? Health insurance. Also, when you look at what's happening, we at Farm Access like to see the healthcare industry as demand side and supply side, right? So when you look at demand side, those that are paying for healthcare, supply side, those that provide healthcare. With the advent of state-led mandatory health insurance, no matter how slow it is, and I know that a lot of people are skeptical about state-led mandatory health insurance, but let me tell you this, no matter how slow it is to take off, just like the telecoms industry took off, no matter how slow it is to take off, at some point it will reach a critical mass and there'll be this huge pool of funds available to fund healthcare industry, not to talk of things like the basic healthcare provision funds. There'll be this huge pool of funds. Now I'm building up to this, to the supply side, to know, because I'm going to end by saying what the supply side needs to do to be able to take advantage of this, right? One thing I found with the healthcare industry is that those that are skeptical, can I say this, end up being philosophers. They just stay and they are talking about the industry. Meanwhile, those that are ready to get on the floor and they actually get some results. And I'll show you how even in the midst of these tough times, some businesses are doing well and some things are happening. So in terms of confronting reality, what's the future of the healthcare industry? Let's look at 3 things. 1 is the policy direction. 2 is the addressable market. And 3 is the hospital performance, right? So if you look at it from the top, and policy direction is macro, or the government's influence, addressable market is the industry, and then the performance of the business. So those are the 3 layers, right? So in terms of policy direction, there will be more favorable policies passed to support healthcare industries. We already saw it with the CBN loan that came immediately after COVID. People who didn't pay attention to the healthcare industry before now are suddenly paying attention. Why? Because if you go back to the slide before, nobody is going anywhere. you are not going to be able to jump on a plane and go anywhere, because the countries where you used to go for treatment have issues. So they will become a more savvy customer who is seeking quality healthcare in Nigeria, right? And policies will support that because it's affecting those who the policies affect. So import waivers, concessionary lending, health insurance, those policies we expect them to come. Government will spend more on healthcare. At one of our webinars that Farm Access had, we saw the Lagos State Governor commit to increasing his spending to even be more than the Abuja Declaration. A lot more governors are beginning to realize that the healthcare industry is really bad, and governments will spend more or devote more of their revenue to healthcare. But even as they devote more of their revenue to healthcare, the truth of the matter is that the governments do not have the money to, that the infrastructural gap, the monies that can meet the infrastructure and the equipment gap. So the governments will rely on public-private partnerships. And this is a big area of opportunity. As the governments begin to rely on public-private partnerships, this is an area where only those who are established, right? Only established healthcare businesses can play. And it's very important, right? More specialists will return from the diaspora to practice in Nigeria. I mean, a friend of mine was joking with me the other day who practices in the United Kingdom. And he said, the minute they open airports, I'm the first to land in Nigeria. And some of these guys have specialist skills. So what it means is that if you look at the $1.5 billion that's spent by Nigerians on medical tourism, the top three are oncology, orthopedics, and cardiology. And so those areas like neurology, those areas like urology, those areas that we've had issues, right? More specialists will flood the market, more funding will follow them, and we will see, better treatment centers, better. And hopefully this will translate to a higher quality of care, right? So if you look at the investment case post-COVID, what's going to happen that will make it good to invest in Nigeria? I already said something about the 1 billion, which is now about 1.5, seeking medical treatment abroad, which means that the market for specialist care exists. If you take oncology, which is the treatment of cancer, for instance, there are probably 4 functional cancer centers in Nigeria. Two functional centers that have state-of-the-art linear accelerators. Those 2 centers have 4 machines between them, and both centers have a waiting list, which means there's room in oncology, right? There's now more focus, like I said earlier, on healthcare. It has become clear that if we don't focus on it, and this is what we have been saying at Farm Access for years, that when the day of trouble comes, you can't start planning. But people now know you can't get up and travel. If you don't develop the healthcare industry in your country, there's going to be an issue. Now, giving a research slide of the Naira from 360 to 460 to $1, it's now more expensive to get treatment, to just get angry and get treatment abroad. So you get angry and say, I just want to go for a checkup abroad. In fact, you have to respect yourself and think, okay, so 1 to 460, how do I process this? Okay, you know what? Isn't there a hospital in Nigeria that can do this thing? I mean, now we are seeing hospitals in Nigeria with state-of-the-art theaters that are doing surgery. Now, the shifts in government policy I spoke earlier, state-led health insurance, the National Health Act, the Basic Healthcare Provision Fund, targeting primary health, because what we have right now is a primary healthcare system that really has failed, right? Now, because that primary healthcare system has failed, there's pressure on the secondary healthcare system to do primary health, right? And once that secondary healthcare system is doing primary health, then there's not much you can get. And so if the primary healthcare system gets fixed, then the secondary healthcare system can breathe and focus on secondary health and actually become better. And we can have better outcomes than we currently have. Now, I said earlier that COVID is a reset button, and this is what I meant. I think it was Winston Churchill who said that a good crisis is too good to waste. You should never waste a good crisis. So when you think about what has happened now, it is an eye-opener. We are lucky, I think so, that the death rate is not as high as it is in even countries with more developed healthcare systems, right? So this focus on healthcare by governments and corporations is likely to increase aggregate funds that will be available to fund projects and pay for services. Now, what must healthcare business do? They must get their business ready for financing. And I cannot stress this enough. You know, we deal with a lot of healthcare businesses, and honestly, this is why we started what we call the Health Management Program, which is by Farm Access and EDC, Enterprise Development Center, because we found out that it wasn't just, it's easy to say, oh, there's no money to fund healthcare businesses. But most of the healthcare businesses we came in contact with were not in a state where you could finance, right? Except you are running a charity. So you find a doctor who is the accountant, he is the CFO, he is the trial balance guy, and he just takes the money and puts it in the account. And on Friday, even if he has a bookkeeper, he just winks at him and says, give me 100 there, 100. And you're touching the money anyhow. And what we always say is pay yourself a salary. Pay yourself a salary, leave the money, let the operations breathe. You know, when we check your account statements, we don't want to start seeing funny drawings. We say shareholder drawings. It doesn't give us confidence. And you have to understand that it is trust that makes the financial sector, industry, go round. If that trust is out the window, then lending stops. If I cannot trust you that you have set up an entity that is different from yourself and you will leave the resources of the entity, then I can't give you money. And sometimes you look at that financial thing and you see a pattern and you say you won't lend him, and then you hear, oh, these banks don't want to lend to healthcare, or they don't want to lend to healthcare industry. The truth of the matter is that you must get your business in a state where it is ready for financing, right? Now, another thing we begin to insist on is emphasis will be on efficiency and quality. So we have the safe care methodology in Farm Access. It's very important. We insist on it, right? On quality. We are even now beginning to insist for larger projects on environment, social, and governance, right? So you cannot do things like a one-man business and expect to grow into a billion-dollar enterprise. You have to be ready to do things. In fact, right now we are even insisting that if you are going to set up a large hospital project, you must get a hospital management company, because we want you to either focus on that or focus on the clinical. We have found in our experience that it is tough to focus on the clinical aspect of medicine and focus on the business aspect of medicine at the same time. It is very tough, right? It's sometimes a recipe for failure. Very few people are able to do that and succeed, right? Now, one of the far-reaching effects is the massive inflow of equipment as most of specialties are being established. If you think about just COVID alone, think about laboratory testing and molecular testing, molecular laboratories. As of January, we had very few PCR machines in Nigeria. Just because the Lagos State government opened testing to private labs, the number of PCR machines in Lagos State as of today has doubled. And that's what I mean by COVID being a reset button. We have used COVID, right? The government has used COVID to reset that molecular. There's now capacity, training has happened. You know, people like Dr. Okpao, you're probably involved in training because he's an IPC expert. Training has happened, and there's now capacity in the molecular laboratory testing, DNA, tuberculosis testing, and all that. The question we need to be asking is, how do we use it to develop secondary health, primary health? How do we use it to jumpstart our health industry, all right? And that's what we need to be asking. As diaspora specialists influence to Nigeria, it's now clear that the world is a global village. Efficiency will be the order of the day. If you want your own hospital, the question I'm going to ask you is, why do you need your own hospital? It seems to me like you just need a theater and you need to be able to share resources with another hospital, right? And those are the questions we'll start asking, right? So we expect more collaborations, especially between complementary services. Expect more collaboration. HMOs will evolve. HMOs will need to evolve into more nimble organizations. I mean, just thinking about state-led mandatory health insurance, just thinking about that, you know that HMOs have to start considering other things in order to survive. So what to do to benefit? Let's start from the HMOs. Since I ended that on the slide, they have to move up the chain, right? If state insurance, health insurance works, then it's going to encroach into their businesses. And so they have to move up the chain. And it's going to, so the structure of the industry fundamentally has changed forever. It may not have manifested yet, but it has changed forever. Again, it's a paradigm shift. And remember what I said about the paradigm shift, that when there's a paradigm shift, everybody goes to zero. That's when new industry leaders emerge. That's when new solutions emerge, right? So they need to become like premium, like Bupa, like premium suppliers. They need to consider things like drug plans. They need to consider things that they've never considered before. Diagnostics businesses need to consider pursuing sophisticated investigations, private and PPP. You need to consider setting up a PPP extension to your business because the government is not going to buy equipment from you anymore. Those days are gone, where the government will buy equipment and they will work for 12 years and you collect your money, or you go around saying they're owing you. Those days are gone. Government is going to employ managed leasing schemes that will make them more efficient. So you need to explore either partnering with an operator to go with your equipment to approach the market. In terms of clinics and primary healthcare centers, they have to leverage state health insurance, especially for hard to reach areas. Primary healthcare centers have to leverage state health, mandatory health insurance. Again, for those who are skeptical, it's just like when the telecoms industry came. We used to use Not 9 Knots. And then GSM came and we thought it would never work. But guess what? It might work at a higher cost. But in Nigeria, our experience is that it works. So in terms of hospitals, improve your quality. Now, this is why secondary health facilities need to improve their quality. Because patients who used to seek medical care abroad are now going to be coming here. So they become more sophisticated, right? And they're going to come. And look, and what will happen is, and we saw this in banking too, patients who have never traveled anywhere to say things like, it's only in this country that hospitals behave like this. You have to take it. And you have to also improve quality. People will demand quality. The new patient is now more sophisticated. For tertiary care, please engage foreign partners. Create the market to leverage their expertise. If you are doing cancer care, for instance, now we're going to ask for foreign partners. If you are doing neurology, we're going to ask for foreign partners. Why? Because it just secures the funding. Engage foreign partners. Now, finally, let me just say how to get your healthcare business ready for what is coming, and then I can take a few questions. So, in getting your healthcare business ready for what is coming, I've shown this chart that winds through. An arrow starts on the left side of my screen. It says, ensure all regulatory licenses are up to date. It's alarming how many big hospitals, they come for financing and there are opportunities to fund them, but they just don't have basic licenses. And you're wondering, CSC is still business name. How can it still be business name, right? 2, ensure your tax is up to date. If you are going to do anything, the government is going to be a big player. Maybe not playing in the industry and offering the service, but regulating. Government will wake up. The Ministry of Health across all states are waking up now. Your tax has to be up to date, right? Ensure also your collateral documents are perfected. So you have a house, one day you want to use that house to lend. However, that house is going to need to be perfected. If you don't perfect it now, it will be added to the cost of your lending, right? So please put your house in order. And then on that side, you must ensure governance is clear. So many times, especially among doctors, they sign what we call gentleman's agreements. There's no clear governance. And if you don't have clear governance, then you're not setting yourself up to play in the big leagues. If you get a board of directors, get a board of advisors, get a chairman that has clouds, get 7 people in your board so that they can help you with what needs to be done in your business. Don't run it alone. Don't try and be a one-man business, right? And then, like I said, regulatory licenses these days now, a farmer in Lagos State, NRRA if you're doing oncology, MDCAN, the license for the professional, the license for the premises, for pharmacies, Pharmacists Council of Nigeria, get all those licenses. Don't operate outside the ambit of the law. Don't run a black market. If you do that, you limit your growth and you limit the opportunities you can take care of. And the earlier you do it, the better. Because when we are asking for criteria, we're going to be talking about how many years you have done this for, right? Again, like I said, COVID has changed the landscape of the industry. It means that with courage and with the right advice, you can do anything. You can do most things you couldn't do before. And that's what a paradigm shift means. What you couldn't do before, you can try to do again. Now, your financial statements, I cannot stress this enough. My team and I go through a lot on these financial statements. Sometimes you ask for financial statements and someone asks you a question like, what kind of numbers are you looking for? As if they can work it for you. It's very scary to us. So we go through a lot. You ask for financial statement and it takes 6 weeks to come. That means the guy cannot access the loan until the financial statement is ready. Let me tell you, nobody is going to borrow you money. You have been doing a healthcare business for 10 years. Nobody is going to borrow you money or lend you money, without seeing what you have done over the last 10 years. It's very important. And your financial statements tell a story of your health, or the health of your business and the performance of your business. So it's very important. And I think finally, have a business plan that shows your short to medium term plans. Invest in a business plan. Don't think that a business plan is only for when you want credit. Sometimes you need it to see if the business is viable itself. So be prepared. I think finally, I'll just say a little about Medical Credit Fund and Farm Access Foundation, which essentially we enabled healthcare markets work on the demand and on the supply side. For Medical Credit Fund, we help to increase the quality of care through providing loans, access to finance for healthcare businesses, pharmacies, clinics, diagnostic centers. We fund equipment and all that. We also provide good advice, technical advice to banks and lending institutions, and we help patients and entrepreneurs, healthcare SMEs prepare their business for lending. So we do quite a bit. On Farm Access side, we help states set up their health insurance scheme. We play on most aspects of the healthcare industry. We have what we call the Safe Care methodology, which ensures quality and ensures a quality improvement plan at any point in time in any hospital. Once again, let me say thank you for the privilege of having to share some of our experience with you. I can take a few questions now. Thank you so much.
Okay, thank you very, very much, Fisayo. I think your presentation, I enjoyed it. And the fact that you looked at the effects from 2 angles, positive and negative, was quite good. I think one of the things I'll take away from your presentation is COVID is a reset button. So it's time to rethink everything that you do. And then we need to position our healthcare businesses for financing, because now emphasis is going to be placed on the efficiency and on quality. Thank you very, very much for your presentation. There are some questions waiting for you. So I think we'll just start. And please, Dr. Opawe, you also have a number of questions before we end the webinar. So this is for Fisayo. Someone wants to know or wants you to share information on health management organizations. I think this is coming from when you mentioned that there will be, now you need to decide whether you want to focus solely on running your practice for clinicals and then getting an organization to look at the business side of it.
Thank you, Anira. So there are companies now that essentially what they do is they are very experienced in managing healthcare businesses. Because a healthcare business is technical, it requires a longer lead time. It requires efficiency. It's not as profitable as other businesses. So these healthcare businesses require specialist care. So there are countries in Nigeria, some people are building the competence now, and there are countries all over the world. Essentially what they do is, a healthcare business is a business at the top would be a board of directors, right? And a CMD, which could be a clinical person. But then, like a COO, so the company takes a CEO, and there are hospitals in Nigeria that have that. So the company takes the COO role, which includes finance, HR, and everything that supports the healthcare business, and they leave the clinical role to the specialist and the owner of the hospital, so to speak, so that they run all the processes, the HR, the finance, and they introduce efficiency. The danger with them sometimes is that they can be very they can take away the human face, but then we're finding a balance, you know. Now, what that does is ensures that the company, the governance is strong. It removes what we call a key man risk. Now, the key man risk is the risk that if anything happens to the doctor, the business is dead. It removes that because the company is also in good hands. Another thing, and I know I'm still sharing my slides, is another alternative to that healthcare business is, like I always say, is a group practice, right? So we use the wolves who run in pack to say that your chances of survival in a healthcare business are stronger when you are in a pack. And so the idea is to be in a pack. You can find a doctor who is not really practicing anymore, who is now into management. They are usually best, you know, for this. So they understand healthcare and they understand the business. You know, that's what a healthcare management company is. Yeah.
Okay, thank you. Again, to you, Mr. Fisayo, please tell us how we can leverage on state-funded healthcare schemes.
Okay, so a number of states have gotten to some places. They've gone far with their healthcare schemes. I know Delta State, for instance, has about 700,000 enrollees. So you need to be watching the states as they grow their number of enrollees. You also need, if you're a healthcare provider, to go and register with the healthcare industry, with the healthcare management agency. You call it empanelment, so they go through a lot of criteria. In Lagos, Delta, there are a number of states that have done that, and you register with them. Once you register with them, then you can take patients from them, and they can pay you what we call capitation, which is an upfront payment, whether patients come or not, for a certain number of lives, or fee for service, which is more a bespoke, experience-based or encounter-based payment system.
Okay, thank you. Someone wants to know or wants you to explain ways small businesses can get their businesses for financing in terms of books.
Okay, I think the first thing is you make sure you keep all records, right? Every single record. You don't need to, if you're a small business, you don't need to hire an accountant. It might be a heavy cost for you. So keep all your records, open an Excel sheet, keep all your records, and every 3 months, you can bring in someone to come and run the accounts, right? But keep all records. I think that's the first step, right? Once you bring in someone to run all the accounts, then you can go from there.
Okay, so you heard it, keep all records. That's the beginning point. I think this is for Fisayo as well. Beyond regulatory licenses, as this doesn't ensure quality, I think it's also imperative that the regulatory agencies have the right process in place to make sure their quality, to make sure they provide quality care. What's your take?
Oh, I certainly agree. And if you see, at Farm Access, that's our position. And one of the things we do is strengthen regulatory agencies to be able to provide that service. It's not, as given the way Nigeria is, a lot of regulatory agencies may be overwhelmed with population growth that was not planned, and they may be understaffed. And one of the things we do is strengthen regulatory agencies, especially those involved in quality, to be able to do the function of regulation, which involves accreditation, validation, and whatever needs to be done to do their job properly. Monitoring, quality improvement, enforcement, and all that. I fully agree. Regulatory agencies need to constantly be empowered and strengthened in terms of their capacity to do that. Yeah.
Okay, thank you, Fisayo. Please don't go away. I want to ask Dr. Okpawe, there's some questions waiting for Dr. Okpawe, so I want to move quickly to him. Dr. Okpawe, this is for you. So someone says, I know of a man that was hospitalized and even used the ventilator. He was treated at home by his wife and kids for a while before going to the hospital. His family tested negative for COVID. How is this possible?
Okay, well, with every disease, not everybody that gets exposed will definitely get infected. So for case in point, the fact that mosquito bites everybody in the house does not mean everybody will come down with malaria. And so it's very possible that the man can be sick and somehow the family don't get it. Also recall that the fact that they were tested once does not mean that further tests will not come up with a positive result. They may be negative at that time, and then further tests may yield positive results. Case in point, for example, we had a case of, say, a vessel that had a single positive case to start with. There were about 52 sailors on that vessel, and then we evacuated the ship. And for what that one, when we went, we tested everybody, and there was only one positive. And then about a week later, we tested the remaining people again, and then we got about 5 positives. And then another 4 days, we tested again, and then we got about 7 positives. So if we had stopped at one test, we would have said, oh, that person was negative. So those are the 2 things to consider. 1, not everybody gets exposed, necessarily gets infected. 2, you may need repeated tests to pick out some people because majority of the infections are asymptomatic. Thank you.
Okay, thank you. Dr. Opawe, someone says beyond testing, how is the ratio of death to testing far encouraging in Nigeria and indeed in Africa than first world powers who are leading the act of establishing solutions using empirical results?
I think, when you say beyond testing, you already validate probably the rest of the question. There was concern that the Central African region, which consists of about 8 countries, since this thing started, are probably not, maybe probably less than 100,000. And in the whole of Chad, for example, there are only 2%. And there are a lot of states in the country that don't have their own labs. Lagos is very long, about several labs. Testing is hallmark, and that's why the WHO will call it test, trace, and treat. They are not testing, they are not taking. So we do not really have a true representation of what is going on in Africa. We have to test how we interpret the data. Because once you say beyond testing, the testing is everything. So you can't go beyond testing. It's not something, the way they say when they say it, no, they show for faith. That they code they show for faith. And so you have a lot of people that are don't know it. And these are people that translate other people that get that. So we can't go beyond testing. Testing is almost the foundation, the benchmark of the COVID, everything rest of it. Thank you.
Okay, Dr. Opawe, we didn't hear you. I think you had some network glitches, so we didn't hear you clearly. If you don't mind speaking up, yes. Please,
okay, great.
Just go over what you said again.
Okay, so sorry. What I was just saying was that you cannot, once you ask a question, say beyond testing, you can't go beyond testing. Testing is everything for COVID. It's not something you can diagnose clinically, right? I mean, yeah, maybe you say this kind of may help and all that, but you need a laboratory test to confirm. So, I mean, there are concerns that a lot of countries in Africa are not doing enough. The Central African region, for example, is talking about 8 countries. All in all, I don't think they've done up to 100,000 tests. The whole of Chad has only 2 tests. So how did they want to test it? They will not. So I think we should be a bit careful when we are interpreting the data from Africa because we are not doing enough tests, we are not picking up enough cases, and a lot more people are probably dying. So we have to be careful and interpret that data looking at the Thank you.
Okay, thank you, Dr. Opawe. Another question for you. What do you think of the data suggesting MMR vaccine conveys some degree of immunity, the MMR vaccine?
Okay, thank you very much, Adiri. Actually, the one I'm aware of is suggesting that BCG vaccine conveys some form of immunity, not even the MMR vaccine. And the emphasis is on suggestion. Because, these are some of the theories that have been proposed as to why the burden of the disease seems to be less in Africa than other continents, because we have widespread BCG vaccination, and some people have thought that maybe there's an association between BCG and something that protects and all that. I think it's important to know that these are all conjecture, and it's not really steeped in science. And what I tell people was that this thing started from China, moved to Europe, from Europe to the US, from US to South America. Africa is the next one, if we are not careful. We may be the next epicenter. And you have Brazil now going to about 2 million cases. So these are just theories. I'm not aware of MMR. What I'm aware of is BCG vaccine, and we don't even do MMR in Nigeria anyway. So I really don't think it's MMR. Maybe the person wanted to say BCG. So it's just conjecture. We're not sure. There's no single data to really support this by protest. We're not sure about that.
Okay, thank you. Just to share a comment from Dr. Wajet, the Medical Director of Pediatric Partners. She says, we have advocated in our hospital for immunization, and they're supposed to start a drive-through. What we have advocated in our hospital for immunization is to start a drive-through vaccination. We have parents stay in their car and our nurses vaccinate the child while in the car. That reduces exposure to our patients. Our nurses have their face masks and gloves on during the period. I think hospitals should think outside the box or out of the box. So that is her suggestion. And I mean, it's something you can adopt at your own hospital for vaccinations. Another question for Dr. Pawe. Why is the government vehemently opposing private health facilities from carrying out COVID-19 testing, aside the few they have approved?
Thank you, Aneri. I think I'll be careful to, in the use of the word vehement,
Dr. Pawe, are you there?
I mean, I think I'll be, connotes very terrible intent. I think the government is also trying to protect our citizens, because we all know that this is a period of crisis, and some people, all they want to do is to profit at the expense of the unsuspecting public. And what we have seen a lot of times.
Dr. Pawe, we've missed out on some of the things you're sharing.
And hello, sorry, can you hear me?
Yes, now we can hear you.
Okay, so sorry. Yeah, so what I'm saying is that what the government is basically trying to protect our citizens, and I mean, I'm not speaking for the lab, but I know the process, and the process is very, very, very straightforward and very, very transparent. If you have demonstrated capacity that you can run this test, please go ahead. And then we're talking about PCR, not.
Okay, I think we have Dr. Pawe's internet connection is
quite straightforward.
Not
you have
very
clear. And then you get your license. So the government is really trying to protect people from unsuspecting members of the public. You can imagine if you come in, you do a test, and they tell you negative, while the test is really positive. I mean, that can be devastating, and that's what the government is trying to do to ensure that quality is delivered across board. And I also want to give a nod to the suggestion from Pediatric Partners. I think that's brilliant. That's an example of an hospital thinking outside the box. And that's really the only way that we can really survive the scourge of COVID-19. We can originate this thing. We have to be brave, and we have to evolve and be dynamic and do things we never, ever thought we couldn't do before. I know some people swear that they can never do this. They no, it's disrespectful. How do you mean? So I will get to somebody's house and they tell the person is baffling. What nonsense. They come to my space. But no, they are not coming. So you have to evolve. Thank you. Okay.
So we'll take 2 questions for Fisayo and probably one more for Dr. Pawe before we close the webinar. Fisayo, this is for you. Can MCF help with business plans?
Definitely.
Okay.
Definitely. Oh yes, definitely. So you can reach out to me and then we can talk about. That's part of what MCF does.
Okay. Can you please share your email address or your contact details?
I will share it in the chat below.
Okay. Okay, thank you. And then what would you change in the Nigerian health system if you had a chance?
So the Nigerian healthcare system is what we call a hydra-headed is a hydra-headed problem, because if you don't take out the right things, then the monster keeps growing other heads. The first place you must start from is policy, right? The right policy. And if you have the right part, that's why you see them saying they want to bring in the National Health Act, the NHIS laws, all the laws that guide what we do as a country. Custom duty policies on importation of equipment. For instance, I mean, for a very long time, a theater light was treated as like a chandelier. So if you were bringing in a theater light, you would spend the same duty as you were bringing in a luxury light. I mean, that's just ignorance, because we didn't know. So the first thing I'll do is focus on policy. And you will find that Nigerians are brilliant enough to take their place and drive the industry if policy would just give way. For instance, again, if you look at mobile money is probably as we have seen in Kenya, one of the equalizers for health insurance or health insurance in the world, right? If Nigeria doesn't kick off its mobile money, it is tough. The same thing with open banking. If we don't allow those policies because we are secretive and some people are holding on to some things, then we are never going to see expansion at a rate that we want. So if I was going to focus on one thing, I'll focus on policy. And I believe that the private sector and the intelligent people we have in government will be able to do the rest.
Okay. All right. Thank you very much. I think someone wants to ask something around financing environmental services.
Environmental services or healthcare services?
Okay.
Or environmental services that relate to healthcare services.
Probably
sure
environmental services that relate to healthcare.
Like effluent discharge for deadlining for oncology centers and high radiation centers. Yeah, if there's a connection to healthcare, and it would make solar panels for primary healthcare centers, if that's what you're talking about, definitely we're interested.
I think I can clarify the question now. And so it says, what is the healthcare financing view with regards to extending financing to complementary support systems, which are not directly healthcare? Yeah, providers.
Exactly. So we are all for it. That's exactly what I was just describing. So they are complementary. If a set of primary healthcare centers want solar panels, hey, we'll do it. Because this is complementary. It's going to make the health outcomes. And I said earlier, Farm Access and MCF, we focus on the patient. Everything we do drives back to the patient at the center, getting better health outcomes. So if that's all we need to do, then bring it on. We will do it, especially with, like I said, lead lining for irradiation, place bunkers for cancer treatment, everything that leads back to, we're definitely interested.
Okay, thank you. I mean, there's so many questions coming in, but I don't think we can continue. I think we'll just give the last question to Dr. Okpawe before we close. There is less emphasis on the use of UV light, or rather the sun, to avert infection. Is it still true that the sun destroys the virus?
Thank you, Aneri. But what we know is that coronavirus, the SARS-CoV-2, is not a very strong one. And we know that just exposure to the natural elements will destroy it after 3 days max, even if you don't do anything. I mean, it doesn't mean you should go and spread yourself in the sun and you get cured of COVID anyway. But if it is on external surfaces, we know that within 3 days it should go. Yes, so we can use the sun creatively and use UV light, especially in trying to disinfect some of our PPEs and reuse them. There's a lot of science going on about that now. But I mean, that's really how that's how that works. But not as if somebody that has COVID should go and spread themselves out in the sun, because I've had that. It doesn't work. If the COVID is outside, yes, it can get easily destroyed. It's not very strong. It's an RNA virus. Thank you.
Okay, thank you. Thank you very much. I think that's about the number of questions we can take now. All questions that haven't been answered will be answered via email. We'll send responses to all attendees via email. I would like to say thank you, very many thanks to the organizers of the webinar, Farm Access Foundation and Novartis. Thank you to our speakers for taking out time to come and provide information that is necessary. I peeped into the chat room and the participants actually enjoyed the information. They said it was a depth of research that was brought on today. Would also thank you, our participants, for joining in. And we say, please follow our social media handles. I mean, we have information there about what we do, about our upcoming events. So please follow our social media handles. Check us out on our website. And remember, wash your hands regularly, keep your physical distance and mask up. Enjoy the rest of your day and bye-bye.